Good evening, respected teachers and my dear colleagues. So today I'll be presenting an ultrasound case presentation. USG-B scan in trauma is basically ultrasound in ophthalmology is 8 to 12 megahertz in frequency, and it is a unidirectional amplitude scan or A scan, and another one is a two-directional cross-sectional brightness scan. So both of these are employed complementary to each other and are often used together. Common posterior segment conditions following blunt and penetrating injuries, which can be diagnosed using ultrasound B scan, are as follows: lenticular abnormalities, posterior vitreous detachment, vitreous hemorrhage, retinal breaks, detachment or dialysis, choroidal rupture, detachment, or a suprachoroidal hemorrhage. First, coming on to the lens. So for the lens, we need to find out the correct presence, whether it's there or not, the position and integrity of the lens, along with the anterior or posterior capsular rupture. Vitreoretinal abnormalities have been reported to be associated with traumatic cataract to as high as 20 to 30% in cases of trauma. Vitreous hemorrhage is one of the commonest findings in patients with trauma, which can be seen as dots or short lines on B scan if it is a recent vitreous hemorrhage, or low amplitude spikes on A scan. And if it is a dense hemorrhage, then it's mostly opacified seen on B scan and higher in reflectivity on A scan. In the vitreous, there can be posterior vitreous detachment, which is usually smooth, but if it is thick, then it is mainly because of the blood which layers around it. A kinetic B scan ultrasonography typically shows an undulating after movement on B scan, which normally allows the PVD to be differentiated from the less mobile retinal or a choroidal detachment. This is a video signifying the same. Here we can see a posterior vitreous detachment with good after movement, a dynamic B scan. Then this is an ultrasound B scan with vector A scan showing lens echo along with low to medium reflectivity membranous echo in the vitreous cavity, most probably the vitreous, signifying vitreous membranes, and the retina, choroid, and the optic nerve head seem to be normal in these scans. Vitreous traction bands are an indirect sign of vitreous incarceration within a perforation site. This may help us identify the sites of scleral rupture, where opposite to them can be sites of retinal breaks or detachments. Retinal detachment is mostly viewed as a bright, continuous folded membrane which inserts at the optic disc with restricted after movements and persists in low gain, like this. It's a high reflective membrane tethered at the optic nerve and with poor after movements. Fractional retinal detachment is shown here mostly as focally elevated retina, which is tethered to the moderate reflectivity vitreous membranes in the B scan picture. And these are the ultrasound B scans with vector A scans showing high reflectivity membranous echoes. About the movements, we cannot say because it's not a dynamic scan, but because of the high reflectivity, we can say that it's a retinal detachment. And a GRT, the undulating nature of the membrane, mostly says that it is a giant retinal tear. Peripheral retinal tears and retinal dialysis may also occur in blunt trauma. This can be detected on a longitudinal B scan by noting the disinsertion of the peripheral retina from the ora serrata, or dialysis when present is mostly seen in the upper nasal quadrant. Choroidal detachment on a B scan is seen as a smooth, thick, dome-shaped membrane in the periphery with little after movement, which can be anechoic to hypoechoic if it is serous. And if it is a hemorrhagic choroidal detachment, then we can see low to moderate reflectivity dot echoes inside the elevations. Posterior scleral ruptures are seen as irregular contours with decreased reflectivity at the site. Indirect signs of scleral rupture may be incarceration of vitreous and vitreous hemorrhage with PVD, demonstration of traction bands or folds that extend in the direction of rupture, thickening of or detachment of retina or choroid, along with episcleral hemorrhage close to the site of disruption. Intraocular foreign body on A scan is seen as a steeply rising white echo spike noted along the baseline between the initial spike and the ocular wall spike. Reflectivity of the lesion spike is extremely high, 100%, which persists on low gain with sound attenuation. The foreign bodies can be metallic, where high amplitude echoes are recorded and where we don't order for an MRI. Can be wood or vegetable matter, where intermediate amplitude echoes are recorded. And glass can be recorded only if the sound beam strikes. Here is a case one. A 28-year-old male reported on 23rd of September with the diminution of vision. With diminution of vision in right eye for around 2 months. Has a history of hammer and chisel injury on 4th of August 23, underwent scleral tear repair for the same, and cataract surgery was done following it. Then multiple doses of subtenon injection triamcinolone were given. His best corrected visual acuity was 1/60, and in the left eye 6/5. 80 was 9 and 12 in each eye respectively. On examination, the superior retina was on, and the rest of the fundus could not be examined because of the vitreous and subhyaloid hemorrhage. This is the axial CT scan image confirming the presence of intraocular foreign body in the right eye. So, the right eye was diagnosed as vitreous hemorrhage with intraocular foreign body with
Actually, in that case, none of the images, the A scan vector went through the eye of P. So when giving images, give at least one image when passing through the eye of P. So which is important. Otherwise, we don't know what is the reflectivity. And same thing, sometimes if you can give the dimensions of the intraocular foreign body, which is also important. And in low gain, whether it is persisting in low gain, an image, whether it persists in the low gain. So these are important in the images which you give.
What are the other things which you want to tell about a foreign body on ultrasound from your surgical planning point of view? Dimensions, yes. What else?
Location.
Location, yeah. So how do you see the location on ultrasound? What location are you referring to here? Yeah, so how do you differentiate these two?
The scan only, sir. Scan.
Yeah. How do you, on the scan, how do you differentiate? When you're doing the scan, whether it is impacted on the retina or it is in the vitreous cavity, how do you differentiate?
Mobility.
Movements, yeah.
So the patient was planned for right eye vitrectomy, belt buckle, IOFB removal along with IOL removal, endolaser and silicone oil injection under LA or GA under GVP. Then second case was a 45-year-old male presented on 6th of February with the chief complaints of diminution of vision in the left eye for last 13 days following gunshot injury on 24th of January. He had swelling, drooping, and redness in the left eye. Patient was conscious. There was a history of bleed from mouth noted and received first aid at a local hospital where ICD tube was placed in the left lung and was further managed to AIMS Patna for treatment. There was no complaint of headache or vomiting. He was a known hypertensive and the left eye was soft. Left eye, the findings were proptosis. There was subconjunctival hemorrhage. Few pigments were there on the cornea. Pupil was fixed and mid-dilated. AC reaction was there along with cataract. And the extraocular movements were restricted in all the 4 cases. Both eyes pupil was round, reacting to light. Left eye RAPD was present. Extraocular movements were restricted in the left eye. Color vision in the right eye was intact. Then left eye iris neovascularization was also noted. On fundus examination, right eye was normal, except for nasal blurring in the disc margins, and left eye, the view was limited, and we could see total retinal detachment and vitreous hemorrhage along with pre-retinal hemorrhage. There was an entry point, suspected entry point in the superotemporal quadrant. Then CT orbit was done, which showed multiple pellets in the apex. This is the axial scan showing the multiple pellets in the apex. These are the artifacts, but multiple pellets were seen in the orbital apex of the left eye and the medial orbital wall.
Ma'am, this is an ultrasound of the left eye. The first scan is an axial scan, which is showing a lens echo. And there is a membranous echo which is extending from the ONH to the periphery, and mostly I can see it in the all the quadrants, and it is moderate to high reflectivity. Now cannot comment about the after movements, so it can be retinal detachment. Usually the thickness looks like a retinal detachment only, other than a vitreous. And in
What
the
else you like to see in such trauma cases? What else you should look for, which is
and
not there in this case, but what else do you look for?
orbital,
So this was diagnosed as a case of left orbital apex syndrome, and patient was started on oral opinion was sought, and left eye lensectomy, vitrectomy, LPFC, endolaser, and SOI was suggested, but upon second opinion, it was decided not to be done. Case 3 is a 31-year-old male.
Nada, was there a entry wound somewhere? Or
Yes, sir.
the anterior segment examination, you didn't tell anything, but in the fundus, you told something is there.
Sir, in the anterior segment examination, no entry wound as such, except for the limited ocular movements and the chemosis and subconjunctival hemorrhage. Pupil was not reacting. There was no entry wound as such.
Okay, the ultrasound also could not pick up any
Any
definite
entry
foreign
wound.
body. Okay, only the CT showed, and that was
CT.
extraocular, right?
Extraocular.
Okay.
Apex and the medial orbital wall. Then 31-year-old male who reported with right eye complaints of floaters and flashes, and a history of sharp stone injury on like 1 month back. Elsewhere, he was diagnosed with right eye post-traumatic choroidal rupture and was started on eye drop Ilevro. He came to us with the best corrected visual acuity of 6/6 in both the eyes and the IOP of 10 and 12 respectively, right and left eyes. On examination, fundus examination, there was an impacted foreign body on the optic nerve head, the right eye, along with few hemorrhages and vitreous hemorrhage in the right eye. In this case, there was a possible site of entry in the superonasal quadrant of the sclera. The left eye fundus was normal. This is an optos image showing the impacted foreign body on the optic nerve head, along with the vitreous heme inferiorly. Left eye was unremarkable, and this is
And this is an ultrasound B scan images of the right eye. The superior image shows the axial scan. The lens echo is seen. The bottom left image shows a high reflective clump echo noted at the ONH with possible back shadowing. The retina appears attached at least in these scans.
How will you see the back shadowing if it's over the
ONH,
ONH?
yes.
so. In this case, also CT was done. I'm sorry, I don't have the plates, but it was confirmed that there was a metallic foreign body on the optic nerve head. So vitrectomy and IOB removal was planned along with belt buckle.
Do you need to do an ultrasound when you can see the foreign body clinically? Yes or no? How many people would like to do? Raise of hands. How many no? Okay. So if you want to do, why? You can see it clinically, right?
And the depth of the foreign body, whether it is impacted or not, that can be.
You can ask the patient to move his eyes. You can see with your IDO whether the foreign body is moving or not.
To confirm if there are any more foreign bodies, like if clinically not visible, and if in case the piece is broken into multiple pieces also, and other places might be get impacted into.
Yeah, there was inferior vitreous hemorrhage. No, there could have been a piece inferiorly also. So you need to rule that out. And medico-legal documentation also sometimes it has a role. Yes, photographic documentation is sufficient, but yes.
It's always necessary to do that ultrasound because other foreign bodies are bound to be missed, or it might be in somewhere in the past plana, and if you don't remove it, it becomes a negligence. It becomes you are not supposed to. Once you have gone inside, you have to completely rule out that there are no other. So for that reason, ultrasound need to be done.
Then a 57-year-old male reported in September with a history of diminution of vision in the right eye for 15 days. And there was a history of injury with fan blade on 28th of August, underwent wound exploration, scleral tear repair, and hyphema drainage with anterior vitrectomy on the very next day of trauma. And patient was currently on treatment with eye drop Duronet 4 times, Hylotears, Vigamox, and atropine. Upon examination, his best corrected visual acuity was PLPR inaccurate in the right eye and 6.6 and 24 in the left eye. Right eye scleral tear repair was done, but it was total hyphema, so nothing could be visualized, and we had to do USG. And left eye, within normal limits, pseudophakic eye. Applanation tonometry, right eye was 15 millimeters of mercury. So,
Next.
The first image is axial scan, where lens echo is not noted, definite echo is not noted, and vitreous cavity has a lot of dot echoes and also some membrane echoes. We can't comment upon the after movements. There is a membrane echo arising from attaching to the ONH, extending to the periphery, and there is a localized dome-shaped echo in the superior part of the scan. There is a globular echo, globular structure seen in the inferior part, could be a dislocated lens.
Okay, go to the next.
then patient was planned for right eye lensectomy, vitrectomy, plus minus relaxing retinectomy, LPFC, endolaser, NSY under LA or GA under steroid cover with guarded prognosis. Both eyes also had lid retraction. Upon testing, thyroid function test was found to be deranged, and he was advised to consult an endocrinologist. Introp findings revealed retinal incarceration in the superotemporal quadrant, along with a posteriorly dislocated lens, a closed funnel retinal detachment where disc was not visible. So, on post-operative day 1, here we could see that the extent of RR is visible. The lasered edges of the RR, there's some heme on the edges, and along with the siliconoid tamponade and a site of incarceration, the superotemporal quadrant. 80 was a bit on the lower side, 6 millimeters of mercury. This is the white field photograph showing the same.
So preoperatively, the ultrasound could not pick up that incarceration, right?
Yes, it was.
Detachment was seen, but okay. So you have to look for that. In a case of trauma, when you know where the scleral wound is, you have to exactly trace the vitreous and see if there is vitreous incarceration there. It will help in your surgical planning.
30 years male with diminution of vision in the left eye for 1 month, associated with pain and redness off and on for 1 year. He had a history of injury with a stick while working with some machine part 1 year back. There was no history of any foreign body exposure to the eye though, and he did not have any systemic illness. Elsewhere, he consulted and was diagnosed as a case of recurrent inflammatory uveitis or delayed endophthalmitis and was advised vitrectomy. Came here for the second opinion, and upon examination, we found the vision was 6.5 N6 and 6.9 N6 in the right and left eye, respectively. IOP was 10 and 8 millimeters of mercury, and his full field ARG was extinguished in the left eye. The responses. Then, upon examination, the fundus was
Why did you want
unremarkable.
to do an ERG? What made you suspect and do an ERG? Do you do ERG for all the trauma cases?
No, ma'am. This is unrelated to trauma. This is a 31-year-old male who reported on 19th of July with the diminution of vision in the left eye for 7 days, along with floaters. And he's a known case of hypertension for last 5 years. His best corrected visual acuity was 6.6 N6 in the right eye with correction, and 6.12 and N8 in the left eye. IOP was 10 and 10 in the right and left eyes. On fundus examination, the right eye was unremarkable. Left eye revealed vitreous hemorrhage along with subhyaloid hemorrhage. And disc was very hazily seen. And peripheral superonasally only retina could be visualized, which was on. And inferonasally, there was a possible neovascularization. Centrally, there was cataract.
Describe the ultrasound here.
This is the ultrasound scan of the left eye. The first image on left-hand side shows no definite lens echo noted. There are few clump echoes seen in the vitreous cavity. Membranous echo overlying the retina with submembranous echo dot echoes noted. moderate reflective. In the right hand side, the scan shows it is the axial scan showing the lens echo with dot and clump echoes in the vitreous cavity. Retina appears attached.
Yeah, describe this.
This scan shows actually the scan is not passing through the clump echo node inferiorly, but vitreous cavity shows few dot and clump echoes with a homogeneous moderate reflective might be clump echo inferiorly with isohomogeneity.
Is it a clump echo or?
It is a mass lesion, suspected mass lesion.
Anyone else wants to describe it?
You told it's a retinal mass lesion. How do you know it is a retinal? It can be choroidal mass lesion also, right? You describe it as a retinochoroidal elevation. Okay, so because you can't differentiate which is the retina, which is the choroid there.
So Nada, you know what is the resolution of the ultrasound? Axial resolution of the ultrasound. Just like you have axial resolution of the OCT. What is the axial resolution of ultrasound? Which is why he said is retinochoroidal mass. You can't call it retina separate, choroid separate. What is the usual thickness of retina? Unless it is detached, you cannot tell retina away from choroid. Any idea? Thickness of retina. Any wild guess? Nobody's going to judge you.
1.2 millimeters.
Too precise, man. Give some range.
1 to 2 millimeters.
Sure, that's a good range. What about choroid? You keep seeing, no, day in, day out, you see the OCT pictures, right?
Yes, sir.
The OCT will tell you the subfoveal choroidal thickness and stuff like that. These people write, no, PPCT and all that. Horrible acronym.
PP.
Peripapillary choroidal thickness, they'll talk it. It's just the worst acronym I've ever heard. They're specifically worried about the peripapillary choroidal thickness. I don't know why. So you'll have this specific, beautiful acronym next to that ultrasound report. They're very concerned about the peripapillary choroid.
Around
then-
2.2, like that.
Okay. And what's the thickness of the sclera?
That's 0.5, 0.7, 1 millimeter, depending on the location.
Correct. So roughly around 500 microns is the whole thickness of this ocular coat. So unless they detach from each other, they separate from each other, you cannot make them out separately. And that's the reason why I said retinochoroidal. So what you should look at is how the A scan reflectivity is within that tissue. So that the line should pass through the tissue to tell you what is the surface reflectivity, what is the internal reflectivity, and whether the internal reflectivity is homogeneous, heterogeneous, which means it can tell you whether it's a very compact tissue or whether it is a tissue filled with different components. So different reflectivities, different absorption qualities. Sclera is the only structure that you can see here, separate from the tissue anterior to it. So you have the highest reflectivity is the sclera. That also you can't you cannot tell about the anterior scleral reflectivity versus a posterior scleral reflectivity because it is too small. Ultrasound cannot give you resolution less than 500 microns. So you can't make out difference between two objects which are closer than 500 microns in ultrasound. They have to be far apart. The resolution is not so great. Okay, the resolution gets better if you have the 50 hertz megahertz probe, but then it doesn't have the depth. So we can't do UBM for posterior segment. You can do only the anterior segment. There you get better definition of the structures. You can make out the resolution is far better. Ultrasound doesn't have that resolution. Ultrasound, we don't need ultrasound for that. We need the depth more than the resolution. And that happens only when the tissues are separate from each other. Like for example, in this, you can see the tissue is separate from whatever it is behind it. Like this here, like this here. What does this show, this image?
So this is this medium to low low to medium reflectivity membranous echo, and in the vitreous cavity. So it's more like a vitreous membrane.
It is not medium to low. It seems medium to me. There's the scleral spike, and then you have the spikes closer to it, almost 75% of that spike, which means it's medium to high reflectivity, actually speaking, closer to the reflectivity of retina and sclera. So this is a medium to high reflectivity, this lesion, and there are double membranes attached to the ONH. You can see the ONH
Yes, sir.
shadow,
Yes, sir.
right? I don't know what section this is, but we do see a double membrane point attachment somewhere close to the ONH. So what will be differential diagnosis there?
That can be a PVD first, then
What PVD?
incomplete vitreous detachment.
Possible. But
And
why is the reflectivity so high?
sir, the blood, it can be blood lined, so that's why.
So why not RD?
So because RD will be attached to both the ends of the ONH, the attachment will not be that
Both
narrow.
the ends of the ONH, not the right
Sorry.
way to explain.
Yeah, it is attached.
Okay, the RD is attached to the center of the optic nerve, but the shadow is not correct. You do have a tissue going across the optic nerve. This means this is a oblique section. You can't comment on that. Secondly, you want to distinguish in RD and PVD, you must look at its after movements
movements.
when the eye moves. So
Yes,
this
sir.
image will not tell you whether it is RD or bloodline PVD. For that, you need to see the mobility of the tissue and where exactly is attaching on the ONH. And RD comes from the dead center of the ONH, whereas PVD can be attached to edges, or if there's a tissue on the center of the ONH, like a fibrovascular proliferation, it will be attached to it. And RD will never cross over each other. Meaning two flaps of RD will never go across each other, not like an X pattern. Vitreous can do that.
Yes.
Vitreous, because vitreous can undergo schisis.
Yes.
Go ahead.
So vitrectomy and endolaser was planned for the patient. Then upon intraoperative evaluation, it was noted a large choroidal mass in the inferotemporal quadrant with surrounding subretinal hemorrhage. One bleeder was also noted in the inferonasal quadrant, which was covered with pigmented layer, which was sent for a histopathological analysis. An endolaser was done to the retina surrounding the mass, as well as to the bleeder in the inferonasal quadrant. This is the post-op picture showing the area of the mass, which is lasered all around, and there was a pigmented area with sclerosed vessel inferior to it, and the laser around the bleeder is also shown here. Then again, the B scan was repeated. This time, the scan shows a medium to high reflective mass lesion in the because in the report it was mentioned inferotemporal quadrant, and we could also see it clinically. So it's inferotemporal quadrant and low to medium internal reflectivity. Then the measurements were taken. So transverse basal was 8.7 millimeters and the height was 4 millimeters. The horizontal basal was 6.95 millimeters.
So ideally, we don't want this picture at all. It's like if I have to name a person, I can write name on his face. Dr. Chetan Rao, write my full name on my face so nobody can recognize me. So this is a very useless way of doing this. You can do it somewhere here if you want to in the black areas. You just tell us where you have put the calipers. That's more than sufficient. But this description at the dead center of that doesn't make any sense. Our dear friend, I know. Let us not name him.
What are these measurements and how do you take them?
So transverse basal will be the longest diameter at the base of the lesion.
What is lateral? What is anterior posterior? So when you take the mass, what is important for us?
So the height will be the anterior posterior.
Height is height. It's not anterior posterior. Height is height. Then you're seeing something in reading. Tell us, no problem. Teleprompter you need. You want to describe a tumor. Important for us to map the tumor and then we need to treat it. Say tomorrow I want to do some kind of a plaque. So I need to know. How will I mention? How would be the standard description? What two measurements I need? Height I know because you mentioned.
The breadth and the basal diameter.
Basal diameter is basal diameter. Tell me, how do you take that?
And transverse. So basal and transverse and the height maximum.
And if you want to do a transverse basal diameter, how do you keep the probe?
So in case of tumor, we take firstly, for example, if the tumor is in the temporal quadrant or so we need to take one transverse scan passing through that area and one longitudinal scan. So in the transverse scan, the pointer has to be longitudinal scan, it has to be perpendicular to the limbus, and in the transverse parallel to the limbus. And so ideally we need height of the tumor and the horizontal extent. So the transverse scan, longitudinal, whichever is the highest height will be the maximum height in either of the scan, and the transverse scan will give us the extent of the tumor.
And what will the longitudinal scan give you?
Anterior posterior.
Yeah.
That also can give.
we need three measurements.
Three
okay?
measurements.
The height you give, which is the maximum height in either the
Either of
transverse
this.
or the longitudinal scan, and you give the transverse dimension and the anteroposterior dimension by the longitudinal scan. Okay.
Looking at the tissue, what do you think this tissue is made up of? You can't separate the retina from the choroid. So as he said, it's a retinochoroidal mass. Looking at the reflectivity, what do you think this tissue is made up of?
So the reflectivity is almost high reflectivity, so it has to be some solid.
Yeah, solid, yes. Solid what? If suppose I said this is a choroidal melanoma, would you agree?
Could be, sir, but the classic signs are not.
Yeah, what are the classic signs?
It has to be a collar stud appearance with the.
Before collar stud, what other things you described? No? What is the classical description of choroidal melanoma on ultrasound? Partji.
No acoustic hallowing is seen, sir.
Again, you went all into the going at the base of the tumor. What about describe the tumor on ultrasound?
A dome-shaped high reflectivity.
That's okay. Dome-shaped elevation. Fine. Next. I have
Presence
told
of
you, no? Surface
internal
reflectivity, internal reflectivity, and
high surface reflectivity, and as the scan vector passes through the mass, there will be acoustic hallowing.
acoustic hollowing. No, it's not called acoustic. What do you call that?
Angle kappa.
Yeah, so what is angle kappa due to?
So ends are high reflective, and the
So sound is attenuated.
attenuated. Yes,
Severely
sir.
attenuated when it passes through the ultrasound, through the tumor. So by the time it reaches the base, the energy is lost. So you get a gradual decline in the reflectivity. So that is why you get the angle kappa, whatever you call it. It's a line from the highest to the base of the tumor. It goes like a triangle with a slope. So that's angle kappa. So what happens if there's angle kappa, and what happens at the edges of the tumor then? So you said no acoustic hollowing. What is acoustic hollowing?
So
acoustic hollowing.
it will be highly reflective, and in between the reflectivity will be low.
So what you have the tissue, choroid, you're no longer seeing the choroid. It appears that it's completely hollow there. That's because loss of energy. By the time it reaches this, there's acoustic hollowing. It's just the choroid is no longer choroid. It is replaced by a tumor. So normal choroidal tissue is you have this kind of hyperreflective bounded by two hyperreflective membranes, and you have in between you. It's not very what do you call low reflective. It's pretty high reflective because it's got vascular tissue within it. So there'll be a lot of reflectivity. It's almost like choroidal hemangioma without a mass. It's almost like a choroidal hemangioma without a mass. But as I said, no, choroid cannot be separately imaged unless it is elevated, right? So you cannot really see the internal reflectivity of the choroid. Only if it is thick, you'll know it, right? So if it is say, like you say in choroidal thickness because of some disease like UV effusion syndrome or anything else, you will see the choroid thick and you will see the internal reflectivity, hyper-reflective, medium reflective, because it's like full of vascular tissue which is dilated. Whereas if you see a VKH is a infiltrative tissue. The choroid looks attenuated within it. It won't have those heterogeneous composition. So similarly, this will appear. This is not a choroidal hemangioma because you see there's so much within it, homogeneous mass, right? But it doesn't appear like choroidal melanoma. There's no angle kappa. It's allowing ultrasound to pass through and then come back to you. So you got a very uniform thing. So we don't know what that tissue is. And neither is it so internally high reflective to suggest that it's vascular. So we don't know whether it's vascular again because we don't see so many. You see the B scan. Now you see the B scan. Once you've seen the A scan, now you see the B scan. Do you see any echolucencies? You don't see. It's a very nice and what do you call homogeneously dense lesion. So it is somewhere in between. It's a pigmented tumor. We don't know what it is made up of, but it doesn't seem to be too vascular as well. Remember, this tumor, this thing has bled. So this tumor has actually bled into the vitreous cavity. And that's why we had vitreous hemorrhage. That's why we had to do vitrectomy. And then we realized that this is a tissue. It could even be a tissue like polyp, which is bled and filled the choroid with blood. Very unlikely though.
Sir, diffuse large hypoechoic shadow was noted behind the optic nerve head in the superior scans. So the measurements were taken and they were around 16.08 into 18.08 millimeters. Further, an MRI was done, which revealed a neurofibroma in the orbit and the axial scans. Then,
They mentioned that in the MRI, neurofibroma.
yes, sir. And then
It's
gives
abdominal wall neurofibroma. I don't know about the neurofibroma in the orbit. They mentioned that in the MRI.
yes, sir. it was.
Okay.
Then MRI was suggestive of neurofibromatosis. Father also has a history, and the patient also gave the history of previous accession of neurofibromas at the right abdominal wall and the left thigh, respectively. Then he was advised to review with a neurosurgeon regarding the orbital mass. So, but the vitreous hemorrhage persisted post-operatively, and the IOP was high. So, patient was given Diamox and anti-glaucoma medication. At the final visit, retina was attached and the mass was the same as before. Topical steroids were tapered and the review was, appointment was given after 3 weeks. So in such cases, there's a risk of malignancy, especially if it is a young patient. The risk is 3% more than the general population. And we should always screen the patients for carcinoids, pheochromocytomas, brain tumors, chronic myeloid leukemia, and malignant peripheral nerve sheath tumors. Malignant peripheral nerve sheath tumors are particularly have devastating complications. So we need to tell this to the patient and to review with the systemic physician as well. So the take-home message was that B-scan helps gather better anatomical information, both in presence or absence of media opacity. Clinical correlation of the lesions detected is very important. Any history of past trauma may reveal a foreign body. And also to keep in mind the possibility of mass lesions in young patients presenting with vitreous hemorrhage or media opacity.